Welcome to this iJournal Club episode. Today we're discussing a comprehensive 2025 review published in JAMA by Dr. Niramish Singla and colleagues on testicular germ cell tumors, an essential topic for all clinicians involved in the care of young male patients.
Testicular cancer is the most common solid malignancy among men aged 15 to 40 years, with around 10,000 new cases annually in the United States and approximately 75,000 cases worldwide. The average age at diagnosis is 33. Historically, incidence was highest in men of European ancestry, but by 2026, Hispanic men in the US are projected to have the highest rates. Importantly, the age-adjusted incidence has nearly doubled since 1975, from 3.7 to 6.4 per 100,000.
More than 90% of testicular cancers are germ cell tumors, or GCTs. These tumors are broadly classified into seminomas and non-seminomatous germ cell tumors, often abbreviated as NSGCTs. Seminomas make up just over half of cases, while NSGCTs account for the remainder. Tumors with mixed histology, meaning they include both seminomatous and non-seminomatous elements, are classified as NSGCTs for staging and treatment purposes. Recognized risk factors include a history of cryptorchidism, prior testicular cancer, family history, gonadal dysgenesis, infertility, and genetic syndromes such as Klinefelter. Interestingly, cannabis use has been associated with an increased risk, with studies demonstrating a clear dose-response relationship. This has important public health implications given increasing cannabis consumption among young men. Clinically, the most common presenting symptom is a painless testicular mass, found in up to 90% of cases. Some men report a sensation of heaviness or swelling, and rarely gynecomastia may be present due to elevated BHCG. Around 10 to 20% of patients present with symptoms of metastatic disease. This may include back or abdominal pain, cough, chest pain, or hemoptysis.
The diagnostic workup should include a detailed history with attention to risk factors, physical examination, scrotal ultrasound, and measurement of serum tumor markers, alpha-fetoprotein, AFP, beta-human chorionic gonadotropin, BHCG, and lactate dehydrogenase, LDH. Scrotal ultrasound has high diagnostic accuracy, able to detect lesions as small as 2 to 3 mm with over 90% sensitivity and specificity for malignancy. Importantly, normal tumor markers do not exclude cancer.
Once testicular cancer is suspected, urgent referral to urology is indicated. The diagnostic and therapeutic cornerstone is a radical inguinal orchiectomy, removal of the testicle and spermatic cord through the groin. Transscrotal biopsy is contraindicated, as it can disrupt lymphatic drainage and alter metastatic patterns. Sperm banking should be discussed before orchiectomy or any systemic therapy. Staging includes CT imaging of the chest, abdomen, and pelvis with classification via the American Joint Committee on Cancer, AJCC, TNM system, incorporating serum marker levels as an S component. The International Germ Cell Cancer Collaborative Group, IGCCG system, further stratifies risk into good, intermediate, or poor prognosis, critical for treatment planning. Treatment decisions are guided by tumor histology, stage, and tumor marker dynamics. Management is ideally performed in experienced high-volume centers where multidisciplinary teams coordinate care. For stage 1 disease, which comprises 70-75% of new diagnoses, surveillance is the preferred approach after orchiectomy, with adjuvant therapy considered for higher risk features. Stage 2 disease, present in 20% of cases, often requires chemotherapy or retroperitoneal lymph node dissection. Seminomas may be treated with radiotherapy. Stage 3, which affects 10% of patients, is managed with cisplatin-based chemotherapy, followed by evaluation of residual masses. Salvage regimens, including high-dose chemotherapy and stem cell transplantation, are available for relapsed or refractory cases. Prognosis is excellent. 5-year overall survival exceeds 95% across all stages. Specifically, survival is 99% for stage 1, 92% for stage 2, and 85% for stage 3. However, delays in diagnosis can negatively impact outcomes and increase treatment-related morbidity.
With survival comes the need to address long-term adverse effects. Chemotherapy, particularly with cisplatin, may lead to nephrotoxicity, ototoxicity, neurotoxicity, and secondary malignancies. There's also increased risk of cardiovascular disease and metabolic syndrome. Many patients experience psychosocial distress, including anxiety, depression, and challenges with body image and sexuality.
Fertility is a key consideration. Sperm banking should be offered early, ideally before surgery or systemic therapy. While many patients retain natural fertility post-treatment, assisted reproductive techniques using cryopreserved sperm may be necessary for some. Testosterone replacement therapy is safe when indicated and should not be withheld unnecessarily.
The article also highlights emerging biomarkers, particularly serum microRNAs such as MIR371A3P, which show promise in detecting viable germ cell tumor elements and may outperform traditional markers in sensitivity and specificity. These biomarkers could refine surveillance protocols and reduce reliance on imaging or invasive procedures.
In summary, testicular cancer is a highly curable malignancy that demands prompt recognition, multidisciplinary care, and a survivorship-centered approach. This JAMA review reinforces the need for risk-adapted management, careful attention to long-term toxicity, and continuing research into novel diagnostic and therapeutic strategies.